glucocorticoid, right? Because the adrenal gland's not functioning. That's hypoadrenalism. I'm going to show you how to recognize hypoaldosteronism in the ER, because it's a really difficult diagnosis to make. To begin, let's review the physiology of aldosterone, or aldosterone, whichever you like. Is there a pointer? A stick. What do I do with this stick? I point at the head. Whoa, it's too high. I'm not talking about it. So aldosterone takes sodium and reabsorbs it from the urine and puts it back in the blood. So if you have hyperaldosteronism, you have hypertension, you have an expanded extracellular fluid volume, right? In exchange, in the distal nephron, in exchange for the reabsorption of sodium, you have excretion of potassium. So hyperaldosteronism usually has hypertension, it has hypokalemia, it has metabolic alkalosis, because simultaneously you're excreting hydrogen ion into the urine and you're reabsorbing bicarbonate. So you have a metabolic alkalosis, hypokalemia, and expanded extracellular fluid volume. So this is a really tricky phenomenon. You can't usually find that expanded extracellular fluid volume because they don't have edema. They can reabsorb sodium till the cows come home, and if it's only due to hyperaldosteronism, they don't have edema. No one can explain that, but they don't. You know, the textbooks give you a magical explanation, but no one knows exactly why they excrete sodium before they get edema. But they get an expanded extracellular fluid volume and they get hypertension. So, if in fact you're have hypoaldosteronism, the opposite is true. You can't reabsorb sodium in the distal nephron, so you have a loss of sodium in the urine. You can't excrete potassium because you're not reabsorbing sodium in the distal nephron, so you have a loss of, you have a buildup of potassium in the blood. You can't excrete it. Okay? So these people have a problem with holding on to sodium. They have a natriuresis. And so they are going to present with volume contraction because they can't hold on to sodium. They have a salt-losing nephropathy, if you will. They can't excrete hydrogen into the bloodstream. They can't reabsorb bicarbonate, so they become a little bit acidotic. Okay? Hypoaldosteronism. When you think about what that means in terms of physical examination, here's the problem. Hypoaldosteronism is not a disease you usually need to treat in the ER, but severe adrenal insufficiency is life-threatening. So this is a problem in the way you think as a clinician. Hypoaldosteronism is not something you need to treat in the ER in terms of the loss of aldosterone or mineralocorticoids. But if the patient has adrenal insufficiency and it's bad, they can die from it. So you have to be able to pick up adrenal insufficiency. You have to be able to pick up hypoaldosteronism in the ER, because what you need to do is find out how they're going to die. Well, how's someone with mineralocorticoid deficiency going to die? Huh?
Are they immunocompromised?
They're not immune compromised, not that I know of. but they have a salt-losing nephropathy, so they can't hold on to sodium. They can't hold on to sodium, so they're peeing out all their sodium. So how might they die? They pee themselves to death. How do you die if you pee yourself to death? Huh?
Dehydration.
Oh, dehydration. What does that word mean? What does the word dehydration mean? No, it doesn't mean electrolyte imbalance. It means lack of water. It means you've lost water. Aldosterone has nothing to do with water. It's in dehydration. Okay, so this is lesson number 2 today. You got to remember to separate sodium issues from water issues. Water is under the effect of antidiuretic hormone, ADH. Sodium is under the effect of aldosterone. So they're not dehydrated, they're salt and water depleted. Because when that sodium rushes out of the kidney, water goes with it, right? We never pee out granular sodium. It's always dissolved in water. So water goes with it. They're salt and water depleted, okay? Because they're mineralocorticoid deficient. So if you're in the ER, you're wondering about someone maybe being, they look a little bit sick, but you're not really sure what they're due, what's it's due to. Always make sure you're taking a medication history. If someone has been on frequent steroids, maybe someone with lung disease who gets put on prednisone every now and then, or someone who has bad rheumatoid arthritis who gets put on prednisone every now and then. But they only take it for a week and then they get off. And then a month later they get put on for a week and then they get taken off. And then a month later they get put on. What happens under those circumstances, this intermittent steroid therapy, is that the pituitary gets suppressed. The pituitary gets suppressed, and so ACTH is not really responsive. It's not really responsive. So if the patient gets really sick, or if they develop adrenal insufficiency, the pituitary is not active enough on the adrenal gland to pull them out of it. And they can develop life-threatening adrenal insufficiency just from their intermittent steroid therapy. That usually only occurs if the patient also gets sick. So if they get a bad infection, or if someone takes it to surgery and operates on them, they're at real high risk of dying in surgery. Now the patient's history might be really non-impressive. They just don't feel quite right. You have to use the word lassitude. Patient complains of lassitude, fatigue. They seem to get lightheaded when they stand up. They have a history that's consistent with extracellular fluid volume loss. They never tell you, I have extracellular fluid volume loss, but that's what their history is like. They get dizzy when they stand up. They can't maintain their volume when they're standing upright. So these are pretty nondescript. Many clinicians, when they get this history, think the patient's just nervous now. Lassitude, fatigue, dizziness on standing. On physical examination, they have evidence of volume contraction. What is physical exam data that tells you the patient's volume, extracellular fluid volume contracted?
Capillary refill?
Capillary refill might kind of be there, but boy, have you been doing capillary refill on your patients? I don't know. Especially when they're old. You know, a guy like me, I don't know whether it's returning quickly enough or not.
Skin turgor?
What?
Skin turgor?
Skin turgor. You done skin turgor on someone old? You pull up You pull up grandma's skin on the forearm when she's perfectly healthy, and it's up there an hour later. Skin turgor, it's always listed as never helpful. Okay, I'm going to tell you this one time. If you don't do it, I'm going to slap you upside the head. Positive tilt test. If you're in the emergency room and there's any question at all about what their volume is, tilt them. It's the only test out there for volume contraction that's reliable. You lay the patient down supine and take their blood pressure and pulse. You sit them up. You don't want to stand them up because they might faint on you. Sit them up, take their blood pressure and pulse, and see if their blood pressure drops 10 millimeters of mercury systolic, they've got a positive tilt. If their heart rate goes up 10 or 15 per minute sitting up, they've got a positive tilt, unless they have sympathetic nervous disease. But that's the test, and it's reliable. If they have a positive tilt test, their extracellular fluid volume is low. It's probably 20 to 25% low. We don't know. We don't have any way to measure that. But it's probably somewhere between 20 and 25% low. Now, what they might also have is hyperpigmentation of the skin. People with adrenal insufficiency, if it's on a chronic basis, have hyperpigmentation of the skin. And they have that because when the adrenal gland is not functioning, you don't have feedback to the pituitary gland, right, from glucocorticoid. And so the pituitary gland is pumping out ACTH. And the cells sitting right next to those cells that secrete ACTH are secreting melanocyte-stimulating hormone, which makes the skin hyperpigmented. So people might just be more darkly complected than they were 6 months ago. Or you might be able to find it in the creases of their palms if they're light-skinned, like me and Paul. You might just look at their palms and see if those creases are hyperpigmented, or lines on the neck, or various places. But by and large, the only physical exam that's going to really tip this off is a tilt test. I don't know why. Maybe it's because it takes a little bit of time. The tilt test is the most underused physical exam technique in clinical medicine. It's just underutilized. You shouldn't do it on everybody you see, but you should do it on everybody who you wonder, do they have extracellular volume contraction? Serums, the blood test. These people are generally hyponatremic. Now, why would that be? They're losing sodium in their urine isotonically. They're not losing more sodium than water. They're losing it isotonically. You always lose sodium isotonically. So why are they hyponatremic? I told you 10 minutes ago. When you think of water, you think of which hormone? Antidiuretic hormone, ADH. Water moves under the influence of ADH. Sodium moves under the influence of mineralocorticoid. So the patient's got mineralocorticoid loss. They're peeing out this sodium in an isotonic solution. And as soon as they get a little bit hypovolemic, their posterior pituitary is blasting out ADH. It's the first thing that happens when you lose volume in your extracellular fluid space. The first thing that happens is the pituitary blasts out ADH and you reclaim as much water as you can get a hold of. And so the kidney is reabsorbing water in excess of sodium. And therefore, in the extracellular fluid space, you're hyponatremic. So most people who present with hypoaldosteronism are hyponatremic. And they're hyperkalemic because they can't excrete potassium. That distal nephron business of exchange for sodium for potassium doesn't work. Their chloride is whatever it is, and their bicarbonate's a little bit low because they can't reclaim it in the distal nephron. So they got a little bit of an acidosis. They got hypokalemia, they got hyperkalemia. What I would do is I would memorize this. I would say, when the patient is hyperkalemic and a little bit acidotic, there's probably something wrong with the distal nephron. Just remember that. Because there are a whole list of things that can be wrong. There can be a whole list of things that can be wrong, but it's a tip-off. When someone's a little bit acidotic and hyperkalemic, bingo, there's a disease there. So now you got a little bit of time to try to figure out what the disease is. But you might not believe it, so you repeat it, and it's the same thing. A little bit of hyperkalemia, a little bit of acidosis. Rule number 2 today. Rule number 1 was what ADH does and what aldosterone. Rule number 2 today is every time you get a serum electrolyte measurement, a basic metabolic profile, anytime your serum electrolytes are put in front of you, calculate the anion gap. Every time. Get in the habit of it. Get in the habit of it. There's a short list of diseases that present with a wide anion gap. There's a short list of diseases that present with an acidosis with a normal anion gap. This patient has an acidosis. We know that because the bicarb is low. Now we want to know, is it the wide anion gap or the narrow anion gap? Have you had lectures on the anion gap? Long time ago. My God, it was weeks, months ago. Okay. So the anion gap is the sodium minus the chloride plus the bicarb. In this case, it's 6 sodium minus the chloride. So it's the anions subtracted from the cations. Are those the only cations and anions in the extracellular fluid space? What the hell are we talking about? Anion gap. Is there really an anion gap in your blood? If there was an anion gap in your blood, your hair would be standing on end. You'd have static electricity on your skin. I would be lucky if my hair was standing on end. Okay? So all the anions are equal to all the cations in everybody's blood, every time, no matter what. An anion gap is just that the fact is we don't measure all the anions and all the cations. We only measure the sodium, the chloride, and the bicarb. Well, we measure the potassium, its cation. We could add the potassium to the sodium. We could add sodium plus potassium minus the chloride plus the bicarb. We could do that. And so it would be 136 minus 124. So the anion gap is either 6 or 12, depending upon how you decide to calculate it. Does that make sense to everybody? In one calculation, I've left out the potassium, and the other one I've added it in. Okay, so the rule is, if you look up what's the normal anion gap, the textbook will tell you 12. But that's not the right answer. The right answer is, somewhere between 12 and 18. And what I do is I give the body and the laboratory benefit of the doubt. And I say to myself, I don't have to explain an anion gap unless it's over 18. If it's over 18, I got to explain it. That's a wide anion gap acidosis. If it's 16, I don't know. I don't know if this is a normal anion gap acidosis or a mild wide anion gap acidosis, I'm going to have to think about it. But over 18, under 18, I don't have to worry about it. This is a normal anion gap metabolic acidosis. If when we're through here, someone wants to look at a really neat explanation of anion gap, I've got that too. It's really, really fun. If you're an internist nerd. Why is that the next? Why is that the next slide? That's not right. Let's go back and talk. I think there's another slide in here. So the patient has a positive tilt. They've got these electrolytes. You're thinking this patient's got a mineralocorticoid deficiency. The only thing you have to do in the emergency room is keep them from fainting. How do you do that? Why would they faint? Because their volume contracted and they sit up or stand up. So you just give these people volume expanders. You just give them normal saline. You just put an IV in them and give them normal saline and fill up their extracellular fluid space for the time being. And then you're probably going to admit them because it's not good to have adrenal insufficiency. Someone needs to work this up, figure out what's causing it, and treat it. But it's not an emergency room treatment. It's not an emergency room diagnosis. All you know right now is that they have volume contraction and you can't explain it. They don't have edema. They've got these electrolytes that look like mineralocorticoid deficiency. You're not going to work it up or make sure of the diagnosis in the ER. You're just going to give them some saline and find someone to put them in the hospital so they can work it up. It takes too long to do this in the emergency room. Is that right, Tammy? Mm-hmm. Yeah. Okay. It's been so long since I worked in an emergency room, I don't know whether I'm telling you the right or the wrong. Okay, diabetic ketoacidosis. Diabetic ketoacidosis is usually seen in people with type 1 diabetes. It's the way most type 1 diabetes presents. A little child gets type 1 diabetes, nobody knows, and they wind up sick, they feel bad, they usually have an infection. Mom and dad can't figure out what's wrong with the kid, they bring him to the emergency room, they got high blood glucose, and they're sick as hell, and they got DKA, okay? And people with a known diagnosis of diabetic type 1 diabetes, who for some reason gets sick and starts throwing up, can't eat. They know not to give themselves insulin, so they get DKA if they're not careful, because a lack of insulin will cause diabetic ketoacidosis if you're type 1 diabetic. On the other hand, there are some people who have type 2 diabetes who can present on rare occasions in the ER with DKA. So it doesn't automatically say that the patient has type 1 diabetes if they present with DKA. They could have type 1 or type 2. You could take their history and they could tell you, I am a type 2 diabetic. I take some insulin, but I'm a type 2. I didn't develop this till I was 53, blah, 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 blah. Okay, so you don't want to think that DKA is only secondary to type 1 diabetes. Okay, this is my favorite little cartoon. This is Insulin Physiology 1. Now, my guess is that when you learned diabetes in endocrinology, you learned about every one of those hormones and every one of those receptors and how they can go haywire, and it was a mess. It was a mess in your head trying to understand all those gliptins and oh my God, there's just so much stuff. With DKA, you don't have to worry about all that stuff. You can ignore it. It's all about insulin. The thing that insulin does that's important in DKA is that it makes glucose go into the muscle cells and it inhibits, in all of normal people, insulin inhibits the breakdown of adipose tissue. And it doesn't take much. Almost any insulin will keep your adipose tissue from breaking down, which is why it's so hard for people to lose weight. There's a hormone circulating in everyone's blood that keeps your adipose tissue from breaking down. When fat cells do break down, they come out into the bloodstream as free fatty acids. Okay, but insulin keeps that from happening. So, if you have diabetic ketoacidosis, if you have a lack of insulin, the adipose tissue breaks down and puts out free fatty acids into the bloodstream. Those are taken up by the liver and they're turned into ketone bodies. The two ketone bodies they're turned into, ACAC, acetoacetic acid, and beta-hydroxybutyric acid. Okay? Those are the two ketone bodies. What's ketone about them? Well, these are keto acids. So as soon as they hit the bloodstream, they're dissociated into a hydrogen ion and a ketone body, and the ketone body is acetoacetic acid or beta-hydroxybutyrate. This is really, really simple. This is really, really simple. The fact that you can't get sugar into the muscle cells means your glucose goes up. So these people are hyperglycemic. And they have a tremendous urine volume. And they have a tremendous urine volume because they have this osmodiuresis. When their sugar goes up, they have hyperosmolality, and that causes a washout of water. When these keto acids hit the bloodstream, they dissociate into hydrogen ion and the anion. The anion is acetoacetate or beta-hydroxybutyrate. Okay, here comes the anion gap again. What happens to that hydrogen ion? It combines with bicarbonate that's circulating in your blood, right? And drops the bicarbonate. And these ketone bodies are now anions that weren't supposed to be there. You're not supposed to have very much acetoacetate in your blood. So now you got a whole bunch of acetoacetate. You got a whole bunch of beta-hydroxybutyrate, and they're not supposed to be there, but they're anions. They're just not measured anions. And so when you do an electrolyte, when you get your electrolytes back, you're going to have a wide anion gap. Potassium's 130, potassium's 3.0, chloride's at 100. So the chloride doesn't help you in any of these things, unless they have a hypochloremic or hypokalemic acidosis or alkalosis. But this is normal chloride. Bicarb's low, glucose is 400. Now, when your glucose is elevated, were you taught how to correct the sodium for glucose? Yeah? You add 1.6 for every 100 above normal, so that would be 1.6 times 3, which would be 4.8. So you would add 130 plus 4.8, that'd be the sodium. And you'd subtract 100 plus 14. Now you've got an anion gap of 20.8. That's a wide anion gap. I got to explain everything over 18. So now I've got a wide anion gap acidosis. I got to figure out what's the anion. Now they got hyperglycemia, so probably this is diabetic ketoacidosis. How do I figure it out? How do I figure out that that's what it is? Measure ketones. You can do it in the blood or the urine. I can just go over and get some of their urine and stick a test strip in there, and it'll be positive for ketones. Now I know this is diabetic ketoacidosis. unless in fact they have ketones in their urine because they haven't been eating. But you can also do blood ketones. They have a high, and then if you go back and retake their history, you'll usually find out, yeah, I've been on insulin. I haven't been able to take it because I've been vomiting. Or they have been taking it, but they got an infection, and the infection made their insulin receptors so resistant to insulin that they became ketoacidotic. Everything about these electrolytes okay? The key here is calculating the anion gap. Do it every time. Get in the habit of doing it every time. Now, it isn't quite that simple. There's a lot of other stuff going on, right? So there's an osmotic diuresis. People who present with DKA are extracellularly volume contracted. They look just like someone with adrenal insufficiency in terms of their extracellular fluid volume. And you can't tell how much contracted they are. But they're big time contracted. By the time they get to the ER, they have had remarkable salt and water loss. So one of the things you need to do is replace their salt water, and you do it with normal saline. Okay? Potassium is low. In this case, it's 3.0. Do they have normal, low, or high total body potassium? Well, we don't know. Where is the potassium in the body? It's almost inside. It's almost all inside the cell. 99% of it's inside the cell. We get a look at about 1% of it in the extracellular fluid space, and they've got a low extracellular fluid space potassium. So the only way we can sort of figure out what to do here is to realize that when one of the things insulin does, like cartoon showed that it moves glucose into the cell, it also moves potassium into the cell, phosphate into the cell, and magnesium into the cell. And so if there was a test, there isn't, but if there was a test that would tell us what's the total body potassium, total body phosphorus, and total body magnesium, we would find that it's low. Patients' potassium's low, their total body magnesium's low, their total body phosphorus is low. Because they've been peeing it out. Can't get it inside the cell, they're peeing it out. Among these three ions, the only one that's an emergency is potassium. What you're going to want to do when you treat DKA is you're going to want to give them some insulin to shut off that acid production, right? When you do that, you're going to move potassium inside the cell. And there's a point at which you reduce the extracellular potassium to an extent that they'll have cardiac arrest. And it's not very far from 3, right? It's just below 2. If you take it down to 1.5, they have a high risk of dying. So potassium, we have to pay close attention to. You don't have to pay close attention to phosphorus, and you don't have to pay close attention to magnesium. Their total body phosphorus and magnesium are low, but it's not an emergency to treat it. In fact, you're probably going to cause more trouble trying to treat it in the ER than if you ignore it. Okay? So this is one of those places where knowing the pathophysiology is not enough. You also have to know, what can I do, what do I have to do, what's important. The potassium is an emergency because if you're going to shut off this acid production with the insulin, it's going to move potassium in the cell. When the extracellular to intracellular potassium ratio gets too low, the patient will have cardiac arrest. Kill them. You don't want to kill them. Kill them is bad. Turns out that unless the patient's infected, which makes insulin receptors not very sensitive to insulin, it doesn't take very much insulin to stop this reabsorption of breakdown of bicarbonate. I mean, acids from the adipose tissue. So you can, it turns out, you can shut off the acid production, shut off the breakdown of adipose tissue with like 1 or 2 units of insulin. Just inject it IV, and they'll quit making ketones. Back in the 1970s, there were all kinds of papers being produced. All kinds of papers being produced about how little insulin can you use to treat diabetic ketoacidosis. It was like every academic in the United States was in competition with each other to see how little can I get away with. Kind of a silly question. It turns out you can get away with a little bit. It takes more to get the sugar inside the cell. So that's not the question. But if you use any insulin, they're probably going to shut off acid production. So now the question is, how do I treat them? Do I treat them with insulin? A little bit. And you treat them with potassium, and you treat them with normal saline. The thing that the earliest mistake you'll make, most likely, is you won't replace their extracellular fluid volume fast enough. The first DKA patient I saw was a 14-year-old girl when I was an intern. And she came in, it was pretty easy to make the diagnosis of DKA. She was a known diabetic, type 1, took insulin, so forth, so on. She had a urinary tract infection or something. She went into DKA. So it was an easy diagnosis to make. I put an IV in her. I started running normal saline because I knew that she needed extracellular fluid volume. And I put a 20-gauge angiocath in her, and I started giving her 125 milliequivalent or cc's of normal saline an hour. And she was laying there. Oh, I'm so thirsty. Please give me something to drink, please. Well, I can't feed them because people commonly vomit when they're in DKA, so you don't feed them, you put them in VO. And I wouldn't let her drink, and I was piddling around with her extracellular fluid volume. 100 cc's an hour is just nothing. Nothing. Luckily, I called the chief medical resident in because he was doing a research protocol to see how little insulin we could get away with. He was one of these guys doing this research. And after he had been there a couple hours with this little young teenager whining that she was so thirsty, he came to me. Instead of whacking me upside the head, he said, "Jerry, when a patient tells me over and over and over that they're really thirsty, I usually believe them." So it was clear to me that I was mismanaging salt and water, and I didn't know how much salt and water to give her. And I said, "Well, what should I do?" He said, "Well, a 20-gauge angiocath isn't big enough to give her what she needs. So put an 18-gauge in the other arm, and then hang normal saline wide open in both of those IVs, and give her 3 to 4 liters of saline, normal saline, until she quits tilting, until she quits putting out urine, until she fills up her tank. You're simultaneously going to be giving her insulin to bring that sugar down, so you'll be shutting off the osmotic diuresis. And if you did that, she would not be putting out any urine until you fill her tank back up. And so you need lots of saline. Most of these people, almost all these people, are young. The only way you would get in trouble with volume would be if they also had congestive heart failure, and almost no one presents in DKA old enough to have congestive heart failure, so, or complete renal failure. So usually they're very easy to treat because they're young and otherwise healthy. and you need to give them lots of saline. Now, it's normal saline. What is normal saline? What's normal about normal saline? First of all, what is it? It's what?
Sodium and water.
Sodium and water. And what's the concentration?
0.9%.
What?
0.9.
0.9 what? Percent. What does that mean? 0.9%. Percent. 0.9. What does that mean? What does that mean? So in chemistry, when you see percent, it means milligrams per 100 cc's, doesn't it? Yeah, that's what it means in chemistry, milligrams per 100 cc's. How many, what is milligrams, how many milligrams of sodium in 0.9%? We don't talk about saline or sodium in milligrams when we're talking about saline or half normal saline or quarter normal saline. So this is a trick question. What's normal about normal saline has nothing to do with normality as you see it in chemistry. It has to do with the fact that its tonicity is like normal blood. It has the tonicity of normal blood. So when you infuse normal saline into the bloodstream, the extracellular fluid volume will go up. When you put in half normal saline, half of it will stay in the vascular space and half of it will disappear into the sodium space, in the interstitial space. So we use normal saline in the treatment of DKA. Now, what I do is I add potassium. I give them some insulin. I usually put them on an IV drip of insulin. And I give them potassium, but I put potassium in its own IV. I put 30 or 40 milliequivalents of potassium in 250 cc's of D5W and hang it on its own pump and run it in over an hour or two. The problem is you can kill people with IV potassium, so you don't want to put it in that IV fluid that you're running wide open because you might give it to them too quickly and then they die of that. So I isolate it onto its own fluid pump so that I know exactly how fast it's going in. Never more than 40 milliequivalents per hour. Never more than 40 milliequivalents per hour. And if you did order more than 40 milliequivalents per hour, the nurses will probably tell you we're not giving that because there's a rule against it. That's the limit in terms of how fast you can give potassium. And you don't give them phosphorus, you don't give them magnesium. You worry about that down the road. What would happen if you knew all this stuff and you said, I tell you, they're hypophosphatemic, I better get a serum phosphorus. And so you get one, and it's 1.2. It's supposed to be 2.5 to 3.5. 1.2, oh shit, what's that? What's the deal on phosphorus? Oh yeah, inside the cell, you gotta make ATP. You gotta get phosphorus inside the cell to get ATP. They're not getting phosphorus inside of it. Their heart probably needs ATP. Goddamn, I better get some ATP going there. So I'm gonna load up a bunch of phosphorus. I don't know exactly how much, but you know, I am a PA, so I'll just write the order. And we'll just run it in pretty quick because they were really low on it. What might happen? There's something in the bloodstream, in an ionized form, that phosphorus really likes. What is it? If you add the phosphorus and this other ion, it becomes chalk.
Calcium.
Huh?
Calcium.
Calcium. Yeah. The calcium in your blood is ionized, most of it, except that it's attached to the albumin, but most of it's ionized. So you take this phosphorus and you put it in there and it's ionized. The calcium phosphate get a hold of each other like stink on manure. And it's chalk, and it gets pushed into gets deposited in the vascular wall, and their serum calcium plummets. So calcium is like potassium. If you lower the serum calcium too quickly, too far, they'll have a cardiac arrest. So you can kill people with IV phosphorus. You got to know how to put it in. You got to know how to do it, and it's not an emergency. They're not going to die. People with DKA are not going to die of hypophosphatemia, even when you're giving them insulin. And what generally happens is people with DKA, you start treating them in the ER, they get admitted to the ICU or the floor, and they keep getting insulin, and potassium, and sodium chloride, and the next morning they feel great. Boy, I'd like to have breakfast. So they get ordered breakfast, and food is packed with phosphorus. And so they replace their own phosphorus with eating. The only time with diabetes, DKA, that you run into troubles with hypophosphatemia that might kill you is 3, 4, 5 days after they're admitted, and they've got problems with their GI tract and can't eat. Now you can drop their phosphorus down below 1, and they could have problems. But the thing to remember is that just because their phosphorus is low is not a reason to treat it IV in the ER. And you're not giving them anything PO anyway, so just ignore it. I gave a talk when I was, I think I must have been chief medical resident. And I was doing a research project on how to replace phosphorus in the severely hypophosphatemic patient, because there wasn't any data out there for that. So I was doing the research, and somebody at St. Anthony's knew I was doing this, and they wanted me to come over and give a talk at a medicine conference on hypophosphatemia. So I went over and I gave this big talk on hypophosphatemia and showed how to treat it and so forth and so on. If you had to treat it IV, here's how you do it. I had just collected the data. 3 months later, I get a phone call from the medical director at St. Anthony's, and he said, "Hey, we got a real problem. We have a 15-year-old kid who came in with DKA, and in the treatment, in the first 24 hours, he died." And I've looked over the chart, and looked over the chart, and looked over the chart. It looks to me like the doctor gave him IV phosphorus, and he dropped his calcium, and he had cardiac arrest, and they couldn't get him back. So, yeah, that's very likely what it was. So the person sitting in that lecture was about hypophosphatemia, and then there was this discussion about how to treat an IV if you need to, that I probably didn't stress enough. You don't usually need to. It's almost never that you need to. Almost never. It has to be less than 1. Even if it's less than 1, if they can eat, you can replace it with sodium phosphate tablets. Milk. Oh, questions about how to treat DKA in the ER? Let's look at 2 problems. A 34-year-old female presents with a history of nausea, vomiting for 2 days. She's felt bad for 6 weeks, but has been working and sleeping a lot. She has decreased appetite, feels dizzy when arising from a sitting position too quickly. She's had no energy recently. She commonly feels dizzy when rising from a sitting position, and that's been going on recently. Her blood pressure is 100 over 70 supine and 80 over 50 sitting. Pulse is 98 supine and 106 sitting. This is a positive tilt, right? So what do we know about her? She's volume contracted. She's extracellularly volume contracted. The other thing that could do this is a lack of sympathetic tone, but her heart rate goes up appropriately. It goes up from 98 to 106, so her heart rate goes up. That means her sympathetic nervous system's probably intact. This is extracellular fluid volume. Her respiratory rate's 12 and she's afebrile. She has a sodium of 136, potassium of 5.5, a chloride of 112, and a bicarb of 14. So regardless of how you calculate it, her anion gap is either 10 or 15, and that's below the 18 that I worry about. So this this acidosis is either a normal anion gap acidosis, or she has that problem we worry about when we see hyponatremia and hyperkalemia with a little bit of a metabolic acidosis. What is that? Someone who's volume contracted? Adrenal insufficiency. Addison's disease, for some reason. So in the emergency room, you only need to begin treatment with IV fluid to resuscitate the extracellular fluid volume. What I mean by that is you don't need to give them aldosterone, and you don't need to give them mineralocorticoid or glucocorticoid. You don't have to treat them with steroids unless they are hemodynamically unstable. I had a young lady who was a friend of my youngest son. They were teaching together, and he called me and said, "Would you call my teaching buddy? She's got a baby that's really sick, and she'd like to talk to somebody." And so I called her. It's a baby. I mean, I'm not a pediatrician, so what the hell do I know? But I called her. She said, "Well, I had this baby, and I had the baby out of Baptist, and the baby had an obstructed upper airway, and they couldn't keep the baby alive without intubating him, and so they sent the baby from Baptist to University Hospital, put him in the neonatal care unit. And they worked this baby up, and this baby had some sort of congenital anomaly of the posterior pharynx and needed to have an operation. And so 2 or 3 days later, they take the baby to the operating room, they do whatever surgery they need to do on the posterior pharynx, and the baby does pretty well, but to help the baby, I don't know why, put the baby on steroids. So the baby was on big doses of steroids in the hospital and then weaned off of hydrocortisone over the next 2 weeks. At the end of a month, he started having trouble sleeping at night and would cry. And then the doctor, she went back in, the doctor said, "We need to reoperate. It's come back. It's grown back or scar tissue or something." So they put him in the hospital, they operate on him, and during the operation, it's cardiac arrest. And so they save him and bring him back, and he goes home on steroids. And 2 or 3 months later, he has to go back to surgery, and he has cardiac arrest again. This is the thing I was talking about earlier. If someone's on intermittent steroids, you have the risk of shutting off their ACTH, right? While they're on steroids, your anterior pituitary is not secreting ACTH. And so the adrenal glands become lazy. They don't develop hypoadrenalism, but they've become lazy. And if you have a big time stress, like a general anesthetic and a surgery, your adrenal glands can't respond quickly enough to get your steroids up and your aldosterone up, which is what's supposed to happen if you're in crisis. So you have a crisis and your adrenal glands can't respond, and you develop cardiovascular collapse. And so we reviewed those charts, and I said, you know, what's happened is they didn't treat him with steroids preoperatively. Both times he arrested, they didn't put him on steroids, and they're going to feel awful when you bring this up. Because they know they should be doing that, they just slip their minds. They give him however much steroids babies need, 20, 30 milligrams of hydrocortisone, and he'll do fine. And he did. And they weaned him off post-operatively, and now, you know, his pharynx is okay, and he doesn't need steroids, and he's fine. Unless the patient is an extremis, you do not need to give steroids. What does extremis mean? It means their blood pressure is so low they're in shock. And you think this is probably adrenal insufficiency, then you give them glucocorticoid. You may give them 100 milligrams of hydrocortisone if they're in extremis. You don't have to have the diagnosis yet, because it takes too long to get the diagnosis. You've got all these hormones you've got to measure. If they're in extremis, and if they look like they're adrenally insufficient, then you give them a little bit of hydrocortisone, and that'll save their lives. A 65-year-old female with type 2 diabetes has been feeling sick for a week. She complains of dysuria and low-grade fever. 2 days ago, she began vomiting 3 to 4 times a day. She's not eaten for 2 days, nor has she taken her meds, which are insulin, metformin, hydrochlorothiazide, lisinopril. She comes to the ER tonight because she's so weak she can't get to the bathroom. She's usually a very vivacious woman. She tilts 90 over 60 to 60 over 40. Her pulse goes from 104 to 130. Her respiratory rate's 24. She's tachypnic. Temperature is 100 degrees Fahrenheit. What are you going to order? Basic metabolic profile. Oh, here's her physical exam. She's oriented times 3, lungs are clear to auscultation and percussion. Heart is a regular rhythm with no murmurs, gouts, or rubs. Abdomen is soft with mild tenderness over her bladder. Extremities show no edema. And we draw some blood. She goes sodium 136, potassium 3.4, chloride 102, bicarb 22. Serum glucose 403. What's the diagnosis? How do you know it's DKA? What information there gives you the diagnosis of DKA? We know she's hyperglycemic, which depending on how long she's been there, might explain her volume contraction, but she's really volume contracting. And she's tachypnic. Why is she tachypnic? Her lungs are clear. She's afebrile. She's breathing off the acid. How do you know she has acid?
I don't, that's suspected. She's breathing faster. She's breathing faster.
She's breathing faster. What's the habit you get into when you get a basic metabolic profile? Calculate the Anion Gap. What is it? I hope it isn't wrong.
12, 15. I don't
It
know.
is 12. It is 12. Oh, shit. Oh, shit. Well, it turns out she's got a normal Anion Gap metabolic acidosis. And you've got access to an old chart. So you look it up, you look up her old chart, and you find out that she's never had an acidosis before. Her acidosis isn't very bad. Her bicarb's only 22, and she has a normal Anion Gap. What are we going to do for her? We're going to give her normal saline, right? Because she tilts like crazy. We're going to give her some insulin because she's hyperglycemic. We're going to admit her because she can't even get to the bathroom. She's probably got a urinary tract infection. So we're going to get some urine to see if she got that. Going to culture her blood. We're going to put her in the hospital because she's sick. She looks really sick. She looks a lot sicker than her lab works. Looks like. I've seen this patient twice. And the house staff missed it both times. What's her diagnosis?
We need to correct the potassium.
What?
We need to correct the potassium, by the way.
Well, you can give her a little potassium, but it's not very low. 3.5 is the lower limit to normal. It's not very low. It's not causing her problem. You get a urinalysis. You get a urinalysis and send it off to see if she's infected. And it comes back, lots of white cells, lots of bacteria, and positive for ketones. What? Ketones? She's diabetic ketoacidosis. Why didn't she have white Anion Gap? Oh, you gotta collect the sodium for glucose. How much is that?
1.6 for every 100 over.
Oh, I don't have it. I should have. Well, collecting the sodium for glucose is 1.6 for every 100. So 1.6 times 3 is 4.8. That's 141. Minus 22 is what? Minus 124. 17. Still doesn't reach this 18 that I demand. Okay. What did I tell you about a year ago? The most important diagnostic information is in the history. It's not in the lab. It's not in the lab. It's not in the electrolytes. It's not in the physical exam. It's in the history. So let's go back to the history. What's this lady tell us is wrong with her? She has type 2 diabetes. She takes insulin. She takes lisinopril. She takes hydrochlorothiazide. She takes metformin. She hadn't taken any of those the last 2 days. Why? She's been vomited. What happens when you vomit? What?
Maybe throw all that stuff up.
Yeah, you would if you took it, but she's not taking it. What's the metabolic consequences of vomiting?
Alkalosis.
What?
You lose chloride.
You lose chloride, and the chloride in your stomach is connected to hydrogen ion. So vomiting causes what kind of a metabolic problem?
Alkalosis.
It causes metabolic alkalosis. You get hypochloremic metabolic alkalosis when you vomit. She's vomited 8, 10 times over the past couple of days. She hadn't eaten anything. And before she gets too sick with her infection, she quits taking insulin because she's not eating. She's afraid she'll get hypoglycemic. So she doesn't take insulin. She develops a metabolic alkalosis. She doesn't take her insulin and then gets metabolic acidosis from her diabetic ketoacidosis. And she presents with pretty good looking numbers. And if you did an arterial blood gas, they would look normal too. She'd have a pH of 7.37, bicarbonate that was 22, and she'd have a PCO2 a little bit low, maybe 30 because she's hyperventilating. So her diabetic ketoacidosis is hiding. And it's hiding because she started out alkalotic. So what happened in her extracellular fluid space is she just titrated that alkalosis with the acid, and now she presents pretty normal. She has what I call diabetic ketoalkalosis. That's not a thing. I made that up. That's not a thing. But I've seen this twice. And the anion gap is normal. The only way to make this diagnosis is to look for the ketones. What you can't explain in her database is her hyperventilation. You can't explain her breathing 24 times a minute. She's otherwise healthy, 65-year-old woman who's got some type 2 diabetes. And one of the rules about diagnosis, about making that, you got to account for all the stuff. You got to account for all the findings. And in this case, you got to account for this hyperventilation. Why is she doing that? Did I miss something on the physical exam of her lungs? She developed a pulmonary embolism. I better start thinking a little harder because I can't explain why she's hyperventilating. She's hyperventilating because hydrogen ion, no matter where it comes from, causes you to hyperventilate. And when that hydrogen ion hits her bloodstream from the keto acid, she has to hyperventilate, even though it rapidly becomes titrated by the bicarbonate that's already sitting there. Tricky, huh? Tricky, tricky.
With their body's physiological response, trying to correct the acidosis by blowing off the heart.
Yeah, yeah.
And you treat it the same? The flu?
Treated the same way, except in both of these cases, we moved her back to the ICU because she was sicker than she looked. She had diabetic ketoacidosis. That acidosis is gonna pop up once you give her sodium chloride. That acidosis will pop up, and so you need to get her in the ICU and follow her potassium carefully and follow her glucose carefully. I mean, I don't know. Today they may treat moderate DKA on the floor. I don't know. But if you're in the emergency room, the question you ask is, she's vomiting. She's vomited 3 to 4 times, 2 days in a row. She ought to be a little alcoholic. And you get her blood test, she's a little acidic. That doesn't make sense. Got to explain that. You can get lulled to sleep so fast by not forcing yourself to explain all the abnormalities. Okay? That's all I know about endocrinologic emergencies. I didn't tell you, I didn't finish my story about the hypertoxicosis patient, did I? Well, we're making rounds, and he says there are 6 out of 6 blood cultures positive for strep viridans. He's got what? Yeah, he's got endocrinitis. Where the hell did that come from? Well, I presented the case to Dr. Copeland. He said, this guy's got endocrinitis from a mile away. Vanetta missed it. What does he think's wrong? So he thinks it's hyperthyroid. Does the thyroid come back? Yeah, thyroid's come back. Is he hyperthyroid? Yeah. Well, where does Vanetta think the temperature's coming? He thinks this is probably thyroid storm. Well, I still haven't seen thyroid storm either. And thyroid storm doesn't cause fever. Hypertoxicosis doesn't cause fever. It revs everything up, but it doesn't rev it up enough to cause fever. So if you get a hypertoxicosis patient and they got fever, they probably have an infection somewhere. This poor guy had an infection on his heart valve, for God's sake. I was just treating the beta blockers, calming his hypertoxicosis down. It's a good thing that we do a residency because we're dangerous. We're dangerous without a residency. You will be dangerous without a few years of practice. Be careful. Be careful. Always ask yourself, am I right about this? Am I doing the right thing? Ask for help. Check yourself. Because the patient's lives may depend on it. Okay, any questions?
What is your take, because we had a lecturer earlier last week, Scott Anderson, I believe, that was saying that rather than normal saline, they prefer LRs.
Yeah, that's true. That's true. There's some data, there's some recent data, I think within the last 12 months, where normal saline was compared to Ringer's lactate. I think for volume expansion in situations, and the Ringer's lactate won. Yeah.
Just know that for your boards, again, just like with ACLS and American Heart Association, everything lags in time by the time we figure things out research-wise, and then get it on paper and get it approved, and then it goes through the testing process. So that's where the tricky situation is going to be. Just know that anything brand new that has come up, yes, it's in existence, but it's not going to be on your boards. And that's why we teach the way that we are. If you guys Google or learn anything that's brand new and upcoming, just know that we didn't present that always because, one, we've got a short amount of time to give you what you need to know. And if we do everything that's brand new, it's going to mess you up for your boards. As well as anything that's brand new in medicine, medicine is ever evolving. And you don't know immediately if that's going to be the end all result. They may change their mind again before it's all over again. So again, anything brand new. So for your boards and for questions like this, normal saline is going to be your go-to for DKA.
But if you have a choice, you might have a choice between
In
normal saline and
reality,
lactate.
in-
And
in-
usually they would be the same, because they're both volume expanders.
Right.
And this data on Ringer's lactate is pretty new. I believe it's within the last. Now, it turns out that when I was a medical student and resident in the 1970s, all the surgeons used to expand the extracellular fluid volume was Ringer's lactate. That's all they used. And the only thing the internal medicine doctors used was normal saline, and the pediatricians, normal saline. Why? Because Ringer's lactate just is more expensive, has a much more stuff in it, and it doesn't help. It was our story, and we were sticking to it. It doesn't help. But we were prejudiced against those cocky surgeons. They were prejudiced against the medicine nerds. And so we just stuck to our story, each of us stuck to our story without data. It turns out that when the data has most recently been published, Ringer's lactate wins. Thank you for bringing that up. Any other questions? Yeah.
When you're calculating the anion gap, do you include the potassium or not? Because we
You
kind
know,
of have that
I
one
don't.
read, though.
I don't. I leave it off because it almost never makes a difference.
Okay.
It almost never pushes it above 18, so I leave it alone. It's just easier. But you can.